Good morning, everyone. Welcome to the Combined Critical Care Conference. This is our second one of this academic year. I want to welcome everyone online, trauma, critical care colleagues here, emergency medicine, and Dr. Kneeson from anesthesia. Today, we'll be talking about procedural sedation in the ED and ICU, and my goal is to do it in a way that you don't feel like you're being actively anesthetized. The goals for the talk are to discuss the goals for procedural sedation, go over the pre-sedation assessment, levels of sedation, medication choices, procedural monitoring and logistics, some special populations, talk about some alternatives, and go over some cases, which I think will be some interesting discussion. So when to consider procedural sedation? We see fractures, we perform reductions, dislocations, wounds, complex lacerations. We perform potentially painful procedures all the time, lumbar punctures, thoracentesis, chest tubes, painful INDs. All of these things are, when there's a big component of pain, anxiety that we could potentially alleviate for the patient's sake, are opportunities to consider, not necessarily to do, but at least to consider as part of the treatment plan. Every once in a while, I think that sometimes we encounter patients in this particular scenario. This is from European medical manuscripts, 14th to 15th century, wound man. And you can imagine there's no shortage of combinations of painful things that humans can be subjected to. Penetrating trauma, blunt trauma, wounds, complex infections. All of these things are opportunities to consider. And really, at the end of the day, the no pain, no gain approach doesn't really seem to go very well from a patient satisfaction perspective. So you've got your anterior shoulder dislocation, elbow dislocation, distal radius fracture with dorsal displacement, aka the Colles fracture. You've got your posterior hip dislocation on the left. You've got your nasty looking ankle that just looks excruciating. You've got your complex lacerations that are going to require some time to repair. Painful abscesses, burns. And sometimes we can have procedures that from the get-go, either therapeutic or diagnostic, are potentially very painful. This is one of the more painful procedures that somebody could be subjected to. Sometimes we have to perform immediately life-saving procedures like cardioversion and defibrillation. And sometimes we have to find out what's going on with our patients. And in order to facilitate that care, we need to consider procedural sedation. This is just a table from a community emergency department that performs lots of procedural sedation. You can see the menu and array of procedures that are performed, lots of reductions, chest tubes. And the interesting thing is in a lot of these places, it's a single provider, a single physician that's performing also the sedation as well as the procedure. And you can see the vast majority of those cases, about 83%, is just a single physician with a nurse as the sedation team and proceduralist. And for the most part, quite successful, with the exception of the hip dislocations, which are classically a little bit more challenging to reduce. So here's the procedural sedation patient. There's some indication to consider treatment, and there may be a component of anxiety and pain that we want to address. In this particular case, posterior hip dislocation. So there's a PSA, procedural sedation analgesia potential indication. We perform an immediate pre-sedation risk assessment. We perform the procedural sedation and the actual potentially painful procedure. And then we transition into the post-sedation recovery and disposition. If this is a patient that's going to be admitted, if this is a patient in the intensive care unit, a lot of times you can see this is very relevant to your surgical ICU, but also in the medical ICU, or if this is somebody in the CCT or over downstate. At the end of the day, we have to always ask ourselves, what are the benefits and what are the risks? Not all patients are created equal from this calculus. Not all procedures are created equal. And we really want to ask ourselves, is this a beneficial procedure that we're going to subject and expose our patient to? So how do we do that? How do we actually assess that risk? When do the benefits outweigh the risks? First of all, Age is just one factor, and this is just data that shows that we perform these procedures on the full gamut from very young infant and newborns all the way up to our more than 90-year-old patients. And we've certainly done that at Kings County, and we've performed these successfully. Pre-sedation assessment with the ASA. This is a risk score that was already from the 40s and has undergone several revisions that really takes a look at the medical comorbidity burden and tallies them and asks the question of what is the risk of the patient being exposed to these medications that we're going to discuss. And again, you can see that there's very healthy patients with no comorbidities all the way down to moribund and critically ill. So why is it important to consider the ASA class as part of the pre-sedation assessment? Because you see that there is some relationship between the risk of the procedure and the ASA class, as well as the target level of sedation and the risk of the procedure. So this is a paper from Dr. Al Sacchetti, who's a community emergency department. You see the complication rate does tend to go up with the higher ASA class, and it does tend to go up with a deeper level of sedation. Obviously, that doesn't mean that these things are contraindicated with the higher ASA class or a deeper level of sedation. It just means that you have to be aware of that risk and prepare accordingly. So what are some examples of ASA class 3? Poorly controlled diabetes and hypertension, COPD, morbid obesity, alcohol, substance abuse, dependence, implanted pacemaker, moderate reduction in ejection fraction, and that's typically greater than 30%, regularly scheduled dialysis patients, and history of cardiovascular disease. This is a big proportion of our patients, and we can't exclude a procedural sedation based off of this. It's not a contraindication, but it's something to consider in terms of our plan of attack. What are some examples of ASA class 4? History, there's a big spectrum here of ASA class 4, from just having a history of recent cardiovascular disease all the way to ARDS, DIC, and septic shock. So, and again, severe reduction of ejection fraction is less than 30%. So do we perform procedural sedations in ASA class 4? The answer is yes, but again, it's all about preparation and weighing those risks and benefits and making sure that you're aware of what are all the possible outcomes. Here's a paper that actually looked at procedural sedation, specifically in the emergency department, in what was defined here as critically ill. And I will say here, the definition in this paper was patients that required ED resuscitation in a resuscitation area, and ASA class 3 and class 4. And here they looked at propofol and etomidate and didn't find any difference in terms of the non-critically ill. And these are non-intubated critically ill patients versus non-critically ill at all, and found no difference. Now, again, that definition of critically ill is a little bit loose. It's basically, in our setting, anyone in CCT would be defined as critically ill. They're in ASA 3 or 4. But for all intents and purposes, when you think about patients in shock or sepsis, it's similar to our airway management lecture, how they're going to respond to these medications, you just want to be aware of. Malembody. This is a score from the early 80s, 1983. It's undergone a couple of revisions as well. Started out as a 3-class scoring system, and then they added the 4th. Is this useful? I know we have to do it. It's part of the pre-sedation assessment, but is there a lot of robust data? And I would say the answer is no, there's not a lot of robust data. What it is it's not very sensitive for detecting a difficult laryngoscopy or intubation. It's not very sensitive for predicting who's going to have a difficulty with bag valve mask ventilation as a single scoring system, but as part of a holistic anatomic and physiologic patient assessment, inclusive of the ASA class and an overall assessment of how the patient's going to do, it's potentially helpful. Fasting. Should the patient be fasted? Well, in the emergency department, the answer is oftentimes, if not all the times, the benefits far outweigh any risk of actual aspiration when the patient's not fasted. So there's one paper that talks about specifically fasting in procedural sedation in the emergency department, where a lot of these things happen, sometimes acutely, right after a large meal. And so to delay any potential procedure that's going to treat the patient may be exposing the patient to a lot of unnecessary risk and actually a lot of potential unnecessary pain. But again, we can be logical about this. We can think about this rationally when we stratify what's going on with the patient and what kind of procedure we want to do. So we look at the risk of the patient, and here at the top, the standard risk is really discussing the ASA classification. So our very healthy patients, otherwise patients that don't have a high comorbidity burden. We look at what they ate. So from the anesthesia guidelines, they look at the type of oral intake, if it was clear liquids, if it was juice or coffee with cream or coffee without cream, if it was a full meal. And obviously the heavier the meal, the higher risk potentially, even though it's a very low overall risk, the higher potential risk there is for an aspiration. And then the urgency of the procedure. So if you think back about those images that I showed you, those are emergent, at least quite urgent procedures. Those are procedures that need to happen right then and there. And so for all intents and purposes, the emergent procedures, you can perform all the levels of sedation. The benefits will far outweigh the risks. Now, again, when you apply it to non-urgent and you could wait, then maybe it is potentially prudent to wait. And you have to think about the relevance of your local setting. So in the intensive care unit, if you think about it, those patients are admitted. And if there is, for example, an endoscopy that's being prepared, you may want, I mean, obviously an endoscopy, but for example, if you want to perform a lumbar puncture and the patient's not intubated and you have some time to potentially perform that, perhaps even treating empirically, you may want to weigh that risk-benefit calculus a little bit differently. So again, this is asking that question for the higher risk patient population. Again, the higher ASA classification, is it an emergent or very urgent procedure? Then you can perform all levels of sedation. And again, just going back to the prior slide, the depths of sedation, which we'll discuss, are going from minimal all the way to deep. Levels of sedation. What is our target of sedation? Why is it important? The classic definitions on the sedation continuum are minimal, which is essentially anxiolysis. That's our sometimes PA Valium, Versed, maybe a low dose of fentanyl, all the way through moderate sedation, deep sedation, and general anesthesia. And you can see that the deeper along the spectrum of anesthesia that you go, the requirement for airway and hemodynamic support goes up. So the risk of potential having airway impairment and hemodynamic compromise goes up, and the ability to maintain spontaneous ventilation goes down. Again, knowing what to expect is the way you can prepare, and knowing what your plan of attack is going to be. So how do we define? We can look at the level of responsiveness and ask yourself, what's your target? If you think about the most recent hip dislocation or chest tube that you performed, do you want the patient minimally sedated if you're going through a procedural sedation? Do you want them completely dissociated? Do you want them deeply sedated? Well, we have to ask what that is. So responsiveness, moderate sedation, purposeful response to verbal and tactile stimuli. So the tactile stimulation in this case is a tongue going through your lips. They're going to be quite responsive if that's the target of sedation. So you have to prepare for that. Deep sedation, purposeful response to repeated or painful stimulation. Again, think about the chest tube patient. What's your target? Is it moderate or is it deep sedation? And then obviously general anesthesia, we're not talking about performing general anesthesia, although sometimes we run the risk of drifting from one level of sedation into the next. So the deeper you go, you always have that risk of potentially going into the general anesthesia spectrum. And if you target moderate, you potentially run the risk of running into the deep sedation. So again, just being able to prepare for that. But the responsiveness, I mean, ideally, the goal, it is general anesthesia. We don't want them even responding to the painful stimulus. But again, the risks that come with that is there's often an intervention that's required for the airway, which we don't want. And there's often interventions in terms of hemodynamic management. So oftentimes what we're targeting really is deep sedation, especially for performing painful procedures. So again, going across the spectrum in the continuum of sedation and anesthesia, The further you go, the higher the risk. And it's important to just be able to ask yourself, can I rescue this patient from the depths of potentially going into deep in general anesthesia, including all the interventions that we'll discuss, and making sure that you're actually watching for that, because if it goes unrecognized, obviously we're talking about all the risks of cardiovascular collapse. Medication choices. What's on the menu? We've got propofol, ketamine, fentanyl, midazolam, and Precedex as single agents or as combinations. The interesting thing is these are all the same medications that are just a single medication away from rapid sequence intubation. And they're also the same choice of medications that we use for post-intubation sedation. So just food for thought. You're always just one medication and a dose away from general anesthesia and having the patient intubated. So just always respect that component of the procedure you're about to perform. Propofol. It has its own guideline. That's how important it is. The dose, 0.5 to 1 mg per kg, and there's some variability. You can go up on that. Onset is very quick. Once you give that bolus, the patients tend to go down if you gave them the appropriate dose for that specific patient. I know that you sometimes may have to redose. Its duration is very short, so that's fantastic. That's an important set of advantages to consider when you're performing that. If you're in the ICU and you're about to do a thora, a pigtail, or a chest tube, and you want something quickly to be on for a brief period of time and then to turn right off. It's rapid onset, it's short duration, the patients don't remember. Ideally, it also prevents the nausea and vomiting that sometimes patients encounter after a procedure. Disadvantages: hypotension, respiratory depression, the burning at the injection site. If you pitch it as that means the drug is working, maybe it's an advantage. It's sedation only. There's no analgesia. Again, very good medication for very brief procedures that require a very passive, relaxed patient. Ketamine. Ketamine is used for everything. What isn't it used for? Dose of 1 to 1.5 mg per kg IV, but it could also be given IM. Sometimes it's tough to start an IV, and so we can actually use it IM. Just so you guys know, that's often used in the pediatric emergency department as an option in patients that have very difficult IV access. The onset is very quick through the IV route, a little bit short, a little bit longer through the IM route. And the duration is a little bit longer than the propofol, so you can imagine that you're performing a little bit of a longer procedure, 10 to 15 minutes IV, 15 to 30 minutes IM. Advantages: it preserves your airway reflexes. So if you had any concern about someone's tolerance of propofol from an airway or respiratory depression, this may make you lean towards ketamine. It's predictable and it adds analgesia where propofol is lacking. Disadvantages: emergence phenomena. Raise your hand if you've seen someone at the end of a ketamine sedation have a little bit of an episode. They need some talking down, which is fair. It's a common side effect. It happens often in our adult emergency departments, every now and then in the peds. Emesis. So you can see this is a disadvantage where propofol is an antiemetic. Ketamine actually can potentially cause emesis. Laryngospasm. It maintains your airway reflexes, but if you're manipulating the airway, it may be too much of a reflex and you get a laryngospasm. Now, the rate of that is pretty low, on the order of 0.3, 0.5, less than 1%. But how many sedations do you do in a few years? It's going to be at least 100. So just to be aware that it's something you need to be cognizant of and prepare for. Secretions, hypertension and tachycardia. Ask yourself if your patient is someone that can handle that hypertension and tachycardia. So if we're talking about a heart failure patient with severely reduced ejection fraction, hypertension, coronary artery disease, is this maybe the best way to go? And again, ketamine has its own guideline too, just for ketamine. Ketamine isn't on that sedation continuum because it creates a separate category. It's not on sedation continuum like the other medications. It's unique. And the fact that it doesn't have a dose response curve, it has its own ketamine brain continuum based off of the dosing, starting with the 0.1 to 0.3 milligrams per kilogram, giving you analgesia alone and not dissociating, all the way up through the recreational and partly dissociated to the full dissociative dose. And so with a single bolus of that IV or IM dose, you can achieve that dissociative state. And when you give it IV, you don't want to give it too quickly because you can get apnea. Accommodate. Another medication that we use often for procedural sedation, 0.15 mg per kg, very quick onset, just like propofol, a little bit longer than propofol, much more hemodynamically stable than propofol. Disadvantage, myoclonus. So for a lot of the orthopedic procedures, reductions, if you want the patient to be somewhat relaxed, this may be a disadvantage when it comes to considering your medication choices. And again, respiratory depression, no analgesia, just like propofol. What about propofol and ketamine, aka ketofol, in lots of different combinations? The common one being the 1-to-1, often the 0.5 to 1 mg per kg. Onset 1 to 3 minutes, a little bit longer than your propofol alone and your ketamine, and it's a little bit longer than just propofol. The advantage is it combines the best of both worlds. Airway preservation from ketamine, hemodynamic stability from ketamine, canceling out what propofol will potentially do to your patient, rapid recovery from the propofol, and it gives you some analgesia, so you don't have to necessarily consider any other type of opioid as part of the treatment plan, which runs the risk of some further respiratory depression. Disadvantages are the same for each medication. And depending on the ratio that you use, so for example, if you have a higher ratio of ketamine, you run the risk of having a longer recovery time and some more of the side effects of ketamine. But it's a very good drug for maintaining hemodynamic stability. And if you're concerned about the effects that ketamine may have on the patient or propofol individually, this is a nice cocktail to consider. Precedex. We use it all the time for patients with non-invasive ventilation, to clarify in intubated patients, very safe. In fact, it's very hard to achieve deep sedation. It's very hard. Patients are quite arousable. They look like they're asleep, but they can wake up right away. And so if you think about that for a second, this is the one medication where I sometimes ask myself, should it be on the menu of procedural sedation for painful procedures? It's got a lot of disadvantages. It takes about 5 to 10 minutes to even achieve anything close to deep sedation. I already told you about 3 to 4 other much better medications, and it lasts about 1 hour to 2 hours. Tell me a procedure that you want to do for 1 to 2 hours. Dr. Gleason, I'm calling you if that's the case. Advantages: it maintains muscle tone, provides some analgesia. The main side effects that you want to be aware of, and you'll see this in all of your ICU rotations, is bradycardia and hypotension, and you simply turn it off. And it's longer acting. It's a close cousin to clonidine. It's an alpha-2 receptor that blocks norepinephrine uptake and affects multiple systems. But for all intents and purposes, it takes a while to get where you want to get, time we often don't have, and doesn't often achieve the target that you want to achieve, necessitating the addition of other medications. I think I've shown my bias when it comes to Precedex for this specific indication. I love it for everything else. What about combining ketamine and Precedex in the form of Ketodex? Somebody recently did this. And there's actually some evidence for it. And if you think about it, it makes perfect sense. Just like ketofol, take 2 medications with opposite side effects, put them into the same system, and they cancel each other out. And there's maybe there's definitely studies, there's some evidence, and the real main benefit from this example in pediatrics is that it showed a lower rate of respiratory depression. That's just one paper. And here's another paper. This one is from Belgium, where they did procedural sedation, all the same painful procedures, starting out with the loading dose and infusion of Precedex, and then adding a bolus of ketamine. So it's tough to even say if it was the ketamine or the Precedex that helped. I would say just use the ketamine. Why even complicate matters even more? And look at how much time it took them to achieve the sedation. 13 minutes up to 22 minutes. Think about the last time you gave propofol or ketamine. How long did it take you? Add 20 minutes to that, and then you can start your procedure. But it's food for thought. Fentanyl and midazolam, they're classics. I think that there's lots of other options that we've just discussed. Analgesia with fentanyl, concern for respiratory depression. No analgesia with midazolam, concern for respiratory depression. Tough to achieve deep sedation with these medications without redosing. And then the issues become of now you've given the patient fentanyl and midazolam to achieve deeper levels of sedation, and you may be stuck for a good 30 to 60 minutes until they reverse back. One benefit in pediatrics specifically is the route of administration. Intranasal is great for each individual medication, so you have a lot more versatility. And the other thing is that they each individually have their own reversal agent, so it's great. Procedural monitoring. We've assessed our patient. We've decided we're going to proceed with the procedural sedation. We've planned our choice of med, our target, the depth, the duration, what procedure we're getting ready. Now let's meet with our patient. Let's make sure everyone in the room is prepped, our nursing team, our colleagues, our monitors, make sure I do our timeout, make sure all of our rescue devices are there and readily available. Let's perform the timeout and let's do our procedure. Now, when we perform the procedure, it's time to monitor the patient. And this is really where it becomes a operating for the duration of that procedure. We're monitoring their respiratory status, their cardiovascular system, their blood pressure, end-tidal CO2, and the level of consciousness, which is our target. This is just one scoring system for some background, what our nursing colleagues monitor when we perform these cases. This is called the modified Aldrete score. It looks at the level of activity, the respiratory circulatory system, their level of consciousness, how they achieve the target level of sedation that we're trying to get to, and their gas exchange. We monitor this every 5 minutes while they're under the effects of the sedation and then thereafter. If it's a patient that's going to be going home, which is the vast majority of the cases, this is also a target for prior to discharge. Two main monitors of the respiratory system: end-tidal CO2, waveform capnography, and pulse oximetry. If the patient is on oxygen, you want to make sure you have end-tidal CO2. And I would highly recommend 100% of the time that the patient is on end-tidal CO2. And if the patient is not on oxygen, I don't think that that's necessarily relevant to where we practice, but wherever we end up practicing in the future, if there's some resource limitation, I think that's where the pulse oximetry could be helpful in identifying any kind of respiratory depression or hypoxia. With that said, you should be able to detect that much earlier with the end-tidal CO2. So when we're monitoring our patients, one of our responsibilities as the sedation experts is also to monitor the patient from a patient safety perspective. And we have to know what the outputs of these monitors are. So let's talk about end-tidal CO2. Hyperventilation. Sometimes our patients will hyperventilate and we'll notice a change in the waveform capnogram. We can continue to monitor a patient and typically resolves, but it's important to distinguish it from hypoventilation, where there's actual respiratory depression. And there's two types of respiratory depression, depending on whether or not the patient has an increase in their dead space. So that's our type 2, where you see a drop in their end-tidal CO2, or they're just rhythmic in terms of their breaths per minute going down. And so you'll see a change in the depth and width of the end-tidal CO2 rectangle. And what do you do when you encounter that? You want to make sure you're assessing the patient's airway. Did they obstruct? Are they not spontaneously ventilating? Stimulate them, open the airway, maybe cause with further doses, or maybe reduce the dose, or let them wake up. To even going down to the bag valve mask ventilation if there's any kind of concern for spontaneous ventilation. But this is an early warning sign. It's an early warning signal, so you can make sure you're watching that patient very closely. Bronchospasm. This is that classic shark fin type of end-tidal waveform. You'll see it often in your asthmatic patients or COPD patients, any kind of dynamic airway obstruction. In the setting of a procedural sedation, if the patient have an allergy or an acute asthma exacerbation, you may want to hold your sedation, assess the patient, listen to their pulmonary mechanics, and consider treating that. Complete airway obstruction, apnea, complete laryngospasm, the waveform just completely disappears. So definitely assess your airway, listen for stridor, listen for laryngospasm, open the area, perform your jaw thrust maneuvers. And this is exactly one of the things that we're worried about. This is just one of the risks to be aware of so we know how to respond appropriately. Head tilt, chin lift, jaw thrust, always call for help. There's never any shame in calling for help. Consider nasal airway, potentially up to PVM, even intubation. I would say that's happened 0% of the times in the past year. I hope I didn't just jinx us, but 0% of the times from our procedural sedations. But it's always important to know it's not a 0% chance risk, and just to be prepared for it. So, the spasm. This is Larson's maneuver. If you sense that there's a laryngospasm, if you happen to fall in that 0.3 to less than 1% chance case on that day, it's pressing behind the angle of the mandible at the mastoid process, applying pressure and trying to open up the airway, and even performing some positive pressure breaths. And throughout this process, you're also thinking that the medication that you just gave is also going to be metabolizing. We've talked about respiratory issues, some of the risks to the actual airway from obstruction, hyperventilation. What about hemodynamics? So propofol, sometimes even ketamine, sometimes etomidate, but sometimes it happens. What are hemodynamic reversal agents? IV fluids. Make sure the patient is appropriately fluid resuscitated, not hypovolemic. That just puts them in higher risk for hypertension. And then obviously we have push dose vasopressors, epinephrine and phenylephrine. So something to consider just having as a backup plan. Special populations. Pediatrics. On the pediatric side, in the pediatric ICU, pediatric emergency department, there's a lot of versatility with the medications. Everything is the same with the exception that sometimes the dose that's required is actually a little bit higher. And then all of the airway issues that are associated with the pediatric airway are things to consider. When it comes to patients that happen to be pregnant, thinking about the physiologic changes of pregnancy and how to respond from that perspective in terms of hemodynamics and ventilation and airway management and their aspiration risk. For all intents and purposes, the best fetal care is excellent maternal care, and also always weighing the benefits versus risks. And then in our geriatric emergency department and critical care patient population, the doses at the opposite end of the extreme from pediatrics is perhaps half to a quarter of the dose that you otherwise would have done. So it's something to consider. One calculation to think about is particularly 80 plus 90 is for example, is 100 minus the age could be a good starting dose for propofol. Alternatives to procedural sedation. So what have we talked about, first of all? We've talked about when to consider doing procedural sedation. We see a lot of painful conditions, injury and illness. No pain, no gain doesn't work. We have to be kind. It's our ethical imperative to treat anxiety and pain and perform the procedures when they're necessary. We've risk assessed our patient. We've monitored our patient. We've chosen the appropriate medication. We know what to monitor for, and we know how to respond. But sometimes we have to think that maybe that calculus was the risk may be a little bit greater than the benefit. And that's something that is really a case-by-case basis. Or despite the discussion under a patient-centered shared decision-making model, maybe the patient just doesn't want that for them on that particular day, and they want to hear about these alternatives. So what are the alternatives? Systemic analgesia, topical anesthesia, local anesthesia, intra-articular anesthesia, joint blocks, hematoma blocks, regional anesthesia, general anesthesia. Sometimes, Dr. Kanisian, we need you to take the patient to the operating room. Sometimes, very rarely, but sometimes, very rarely. Because sometimes it's going to be something a little bit more long and more complicated. And sometimes the patient just needs to be under the supervision in an operating room. That happens very rarely. But these are all different things that can be performed in the emergency department in critical care. When we're talking about chest tubes, there's different types of blocks. We're talking about lumbar puncture, both topical and local anesthesia. In the surgical ICU, all of these things can also be applied. And so with that said, we're going to go into some cases. And for our first case, we have a 55-year-old man with a history of hypertension, diabetes, heart failure with systolic ejection fraction of 35%. And this is a large left-sided spontaneous pneumothorax. Dr. Willis, how would you kind of tackle this case? And here, I'm going to pass you the mic and tell me what your input is.
All right, so we have somebody who has active significant comorbidities. I guess I would want to know, is the CHF an active issue? Are they having any respiratory decompensation? Because now you have a decrease in pulmonary function. With this case, I would probably think about regional or local anesthesia, maybe with a supplement of some opioids, and maybe a small dose of benzodiazepine, so maybe a versed fentanyl with local anesthesia.
Dr. Hassel, can I ask you, what would your take be, or how would you tackle this?
Yeah, similar. If we have time, I think you can achieve really good local anesthesia here. You could even consider like a subdissociative dose of ketamine for pain control or opiates for pain control. And I think a lot of patients, if we take our time and really anesthetize well locally, I don't think we necessarily need to reach immediately for procedural sedation.
If it's okay, Dr. Silverberg, it's your turn. I've actually witnessed Dr. Silverberg perform this procedure under local, and the patient was like smiling during the procedure. And I think that's a good point. It really boils down to really emphasizing the local.
I think a lot of lidocaine with epi, get good local control, and inject after you've already made your incision to get the deeper layers. And I think maybe a little bit of fentanyl, it's nice and short acting, quick on, quick off. Plus or minus the Versed. I don't even know if you may need it, but if you get good local, you shouldn't need any of that. You just have to go slow. If it's a crash procedure and you got to do it quick, that's a little bit different. But for somebody who's not in like really bad shape, I think that a fair amount of local plus fentanyl, and then plus or minus a drop of Versed should be just fine.
Patient is totally stable, for chest pain, but otherwise not that toxic. And they have stable comorbidities. You would probably say that it's an ASA classification by that definition. Diabetes and hypertension is very well controlled. You have to be greater than 35%. People are about. You don't use any agent for chest tubes. Yeah. I'm not talking about it. Hang on. I hear you.
I think they can hear me. We rarely use any sedation for this procedure in the Bronx suite. Just good local, yeah, I think is enough. I mean, look, if it's an anxious patient and you want anxiolysis and you want to give a little benzodiazepine, like you mentioned, I think it's fine. And if it's an emergency, you're just putting the tubes. So right.
Right. Fair enough. Just to emphasize, it's, so far everyone has said no procedural sedation. They all chosen the alternatives. It's not wrong to do procedural sedation, but again, if you can achieve what you need to achieve with alternatives that don't have all the resource and risk requirements, something to consider. Case number 2. This is I wrote this for everyone, including our ICU colleagues. 55-year-old male, hypertension, diabetes, presenting with first-time seizure, altered mental status, fever, headache, or nuchal rigidity, and wanted to perform the lumbar puncture. Dr. Gorga, how would you take this? And the patient is a little agitated and combative.
Yeah, it depends on the setting. Like the ER might be different than the ICU for this. I don't know. They've already gotten the benzo for the seizure. Maybe they're relaxed now. Maybe they're not. Maybe it depends on, I guess, vital signs and everything else. If your vital signs are totally stable, maybe local and Precedex. Yeah, maybe local and Precedex, being careful with the local because you don't want to put it in the wrong place for this particular procedure. But yeah, I wouldn't do much. it's not, I mean, I've not had one done. I think it's worse after the fact for the patients from what I've seen. I don't know that it's that painful a procedure when you're putting the needle in, if you do it right. Bust out your ultrasound and put it between their bones.
Dr. Silverberg, I see you raising your hand there. We're an hour and a half into this procedure and there's a lot of movement. The Precedex isn't doing what you want it to do.
So first of all, I think ultrasound is never the answer. Let's pretend you're a doctor, you know your anatomy. No matter how big they are, you can still find the vertebra. First of all, make sure you're in the midline. Go up higher on the back where there's less fat and measure out the spine. So you know you're in the midline. I've seen people go off the midline before, including myself as a junior resident. Lots of local. I usually do a 4-quadrant block where I don't block the midline. I'll block high left, high right, low left, low right. So I get every single nerve coming into the space. If you don't scratch the bone, it's not painful. And then for this patient, I would give fentanyl. I think a lot of my colleagues go with Versed, but you're doing a painful procedure. Why would you just put him to sleep for that? Give him a drug that puts him to sleep and has analgesic properties. This is the perfect case for fentanyl.
I'm going to push one more time, just a little touch. I'm going to say that was tried. Hemodynamically stable, tachycardic, disease fibrotic, and post-critical. And you just wanted to help. You've already started with you give it up. And you did the local anesthesia, give more. It's not, you're worried about actually even getting a needle stick at this point. They'll go to sleep, I promise. And anyone can participate. But, you know, Dr. Hassel, how would you take this? Or would you do the same thing? And that's okay.
I do the same thing that they all say, but if you're trying to push it to a crazy situation where everything's not working, I still consider ketofol then, like if I really have to grab something. And if the pressure can tolerate it a little bit more on the propofol side than the ketamine side of things. But I like to mix them whenever I have to go that route.
No right or wrong answer. So this is a 70-year-old female, history of OSA, COPD, heart failure, reduced ejection fraction 30%, alcohol dependence, presenting after a fallen outstretched hand, foosh, after eating lunch, just walked out of the restaurant with right-sided distal radius fracture and an anterior shoulder dislocation. Sometimes that happens. The impact is the vector forces on the hand that fell. Yeah, Dr. Hannison, how would you take this? I mean, what would you do in this case? I'm signing out to you. If I see this, I'm actually waiting to sign out to the next post-it, even if it's in the beginning of my shift.
First, I want to know if Dr. Silver would use ultrasound for this one. He probably would. I would definitely consider a nerve block for this one. So separately, you have a couple choices. I think if it's just a shoulder dislocation, you could do an intra-articular ultrasound guided block, or even an interscaling for the shoulder. Unfortunately, the interscaling won't get the wrist. It's only good for C5, C6, C7. So you could try something like the supraclavicular brachial plexus block to get the shoulder and the wrist, which I would probably use for this patient. The only risk would be for the interscaling for this patient, something to consider. You can get hemiparalysis of the diaphragm. So if they are in respiratory distress or if that COPD is an active issue, you may want to be careful with that block. Now with the supraclavicular brachial plexus, you don't get that risk. And that would be the safer one in this option, and keep that pleural line in view. So don't keep your needle away from it.
It sounds like also here, 2 separate doses of light. You want to start to considering the lipotoxicity dose too. You know, I think you're not approaching that. I didn't say you were approaching that, but just something to consider if you're going to do some hematoma blocks, maybe 1 or twice, and then depending on what volume. But yeah, I agree. That's a really good point. Dr. Willis, would you approach this in any different way or?
The one thing I just thought about with this is just realizing, I think other than if you're Dr. Hannison and you can have a regional block that gets both of them, I think even in that case, it's 2 different procedures. I think that's something to remember. So prioritize what you're going to do first and realize even let's say you do a regional block that gets both of them out, this poor 70-year-old woman is going to need a break probably in between you pulling on her shoulder and then pulling on her wrist. So consider that in terms of how you plan it. So maybe you give a short-acting sedation for the shoulder, something like ketamine, and then you come back and do a local hematoma or regional block for the wrist. So I think you have to plan that with this. It's not it's a more complicated situation with the two problems.
Okay, and this is a not so infrequent case. So we see a 35-year-old male right after a large meal. This is in the winter, so it's a slip and fall in the ice, presenting with that foot, and the patient's neurovascularly intact. Dr. Hassel, how would you take this one?
I think since everything's intact, right, you can, same thing, take some time and try local anesthesia, right? We're saying the large meal, the idea that there could be risk of aspiration. So I think trying to get good pain control, a lot of times just the reduction itself produces the most pain relief. So if you can just get the patient to get enough local anesthesia and get it somewhat reduced, a lot of times the pain's a lot better. And then if you really can't get it reduced, you can wait a little bit of time before you can proceed to procedural sedation to do a more complete reduction.
Doctor, how would you take this case on?
I think as like everything else, it involves a conversation with the patients.
The patient's screaming right now.
Right, so this might be somebody who I would definitely
Not
consider.
common, by the way. That's what you hear, and then you go and you see the foot looks like that.
Right, so then you're gonna start initially with the systemic pain control, obviously, and the hematoma block and see what happens. You know, I'm not a huge fan of blasé moderate sedation, because we never do moderate sedation ever. I've never seen that actually done in the emergency department. I've seen a lot of deep sedation that we label moderate sedation. And there is risks involved, but I think this is definitely a patient who I would definitely consider doing it and try to stall a little bit to do it.
I just want to point one thing out. The neurovascularly intact makes it a little more relaxed, but do realize that the skin is tenting. So I wouldn't wait too long for this.
Yeah, fair enough. I love how I'm giving a procedural sedation doc, and so far no one wants to do procedural sedation. It's just for the record. So this is our last case. 80-year-old female, history of hypertension, diabetes, COD, presents after a fall with a left-sided posterior hip dislocation. Not an infrequent presentation. Dr. Silverberg, how would you tackle this?
Start with fentanyl, but if it didn't go back in, then I would go ahead. Yeah, but these are pretty hard to get back in. You have to pull really, really hard for it to work. This is not like, oh, give it a little try. These require a fair amount of strength and energy to put back in. But I would try fentanyl first, and if that failed, then ketamine.
Dr. Hanson, how would you take this?
Yeah, this is a tough one. If she's hemodynamically stable and I actually would prefer maybe a little bit of propofol in this case to relax her. The ketamine might cause her to spasm up and might make your reduction a little bit tougher. Or you have the option of doing ketofol with a little more propofol for the analgesia, and then you don't have much of the hypotension effect.
Thank you. Dr. Willis and Dr. Hassel and Dr. Schechter, how would you guys take this case?
I prefer ketofol in these cases.
I'm ketamine, ketofol, propofol, fine. I probably, if I'm picking myself, I'd pick propofol.
I'm a ketofol guy, but I don't really care what you want to do. I would do sedation though, or native hip.
Oh. I think I would do the propofol or propofol and just appropriately dose for the comorbidities in patient age. Again, for the same reasoning of trying to really make sure that the patient is relaxed, because once you get that spasm, and ketamine sometimes doesn't give you the perfect relaxation, it can work against you. And again, this is where etomidate also works against you because of that myoclonus. That is it. We talked a lot about different components of procedural sedation, risk assessment, when to consider it, all the different types of procedures, the different settings, how it's relevant to all of our practice, what to monitor for, how to dose, some of the considerations. I think we had some really interesting discussion. I want to just open up for a couple of minutes if there are any questions, comments.
Sorry, does anybody want to comment on Haldol? I feel like a lot of times we do combine that with, like, I've seen that used multiple times for LPs too. Like, like using that scenario, I've seen mostly Haldol, especially we're worried about like respiratory depression and like an elderly patient we're worried about. Um,
So we have a question about how well in these settings?
I mean, I think Haldol is a great thing to go to when you're considering the geriatric agitation because you don't want to necessarily want to use benzos. When you're sedating, I think it just depends on the mechanism. So think about why you're sedating. If it's a demented geriatric patient with like some psychotic or agitation features, then I think Haldol is okay. If you're sedating because of underlying medical or intoxication, then I would probably go more towards like benzos.
In the ICU, any comments? Are you guys performing this a couple times per month, or Dr. Ferranchi?
Well, in terms of LP, what I would say is the one time, I think 2 times in my career I've been stuck, and once was doing an LP and the patient just flipped out, and before I could put the stylet back into the needle, I had to pull the needle out, otherwise he was going to injure himself, and that stylet is razor sharp. So I would say do what you have to do in order to get, just like sometimes, you manage an airway because you need to get a head CT. If the patient's that agitated, I would do the same thing for an LP.
Dr. Feinberg, good morning. How's it going? Are you guys having are you guys performing procedural sedations in the neuro ICU side? All right, I'll bring it over to you.
So that was loud. All these conversations are with patients who are awake and alert and cooperative. I think what brings you into a totally different category is your non-cooperative patients, right? People can be in pain, but you tell them, I'm doing this procedure to save your life or your leg or whatever it is. I know it hurts, don't move. And they'll listen, they'll scream, but they'll listen. You move that into your intoxicated or your brain injured patients and they can't process that, right? Like no matter how much you tell them to lay still, it's not happening. And I think so in our cases, we tend to favor what Dr. Schechter was saying, the moderate sedation that's really deep sedation, or the accidental deep sedation, because we keep on giving it until they're still. The most important thing in that case then is it's okay to use deep sedation. Just make sure you have your rescues available. And from a resident standpoint, the things that I messed up the most in residency is make sure you have someone with you that can call for help when you need it. A lot of times we try to do things quickly because we're in a rush, or the nurse is busy at the time and you're in the room doing a procedure by yourself. And then there's no one else to help you, especially if you're doing a procedure where you're sterile or you can't stop if something happens. You need someone who can call for help or who can get respiratory or who can bag the patient with you. So make sure the nurse is in the room. It's supposed to be a 1-to-1 ratio when you're doing sedation, and just make sure that's happening. Other than that, from the nice person point of view, procedures hurt. And if patients are screaming, don't tell them to take a deep breath or just to be calm. Like imagine if this is getting done to you. I definitely tend to over sedate patients because I'm just don't like pain. And so keep that in mind.
Great, thank you. We've got a comment from Dr. Silverberg, and then maybe one more comment or question, and then we'll close.
I think you really need to think about what you want to achieve. If you're doing an LP on a patient that you want to send home, then use something short acting that will be gone so you can send them out. But if you're doing it on an admitted patient that's going to stay in the hospital, that potentially may give you pain during your procedure, then use something super long acting, like, a Haldol or something. Just, it depends on what you want to do with them. If they're going to be admitted, making them sedated for a long time is not necessarily the end of the world. But if you want to send them home and they spend 6 hours recuperating from your procedure, then that's not the right way to do it.
Last comment, one last comment from Dr. Gernsheimer.
Yeah, so if you're going to do a very quick kind of procedure, like doing a CAT scan in an older person, you really have to see if they have a subdural, or you're going to do an LP in an older person. To be honest, I like Versed. It goes on quick, it comes off quick. Yes, they may get respiratory depression, so you have to watch them. But, and then for the pain, yeah, you give the local anesthesia. But if they're jumping around, you're not going to get that LP very easily. The other thing is, with older people, as you mentioned before, it's always good to start a little slower than you would. Start low and go slow. And that's our motto in geriatric EM. And finally, one thing I just wanted to mention about the chest tube patient. One of the things I would do is use a pigtail rather than a chest tube because they're smaller, they hurt less, they're easier to put in. So I'll always think about that, particularly in little old people like me.
Thank you. All right, thank you. And I think with that, we will close a few minutes early. Just wanted to thank everyone for their participation. Unless there's any last questions, thank you to everyone who joined online and everyone who joined us from critical care and anesthesia. And I think the great thing about today's day is that the alternatives to procedural sedation, led by Dr. Hannison, at around 10 o'clock, there'll be a workshop on regional anesthesia and some nerve blocks. So even our IC fellows are invited to observe just to get a little bit of exposure to some other alternatives that you can offer in the critical care unit, especially in your SICU and NICU and neuro ICU rotations too. So something that we could all learn from each other. Thank you very much, everyone.